All right, we are going to take a massive shift in direction here. You've heard a lot, I think, today in terms of detailed at the granular level process and methodology. And I've been charged with the fun task of really talking about emerging science. So I'm going to give you a little bit more of a high-level philosophical view in terms of where I think and hope the use of pharmacogenomics and genomics are going, specifically in the world of cancer here at IU. And so as I give this talk, I want to be very clear there are a lot of caveats. I could give a 3-hour talk on the hurdles and pitfalls of this approach, but really want to instill some enthusiasm for what I believe to be the real potential of this sort of approach. So with that being said, as we talk about really the future of where I think cancer is going, I think the best place to start is where we came from and the very, very beginning of our understanding of how we applied therapy to cancer. So for those of you who've not read, this is a great book called The Emperor of All Maladies. And in this book here, you see an example of really the first recorded history of cancer. This is from an Egyptian text from 2500 BC, where the healer diagnoses a bulging tumor in the breast, and unfortunately, based on his experience, told the patient there's really no treatment for this. And I'm going to use kind of breast cancer as a example of really what is all solid malignancies, but breast cancer is kind of cool because it is a superficial organ, the breast. And so because of that, there are literally tons of references throughout art and history. This is a sketching from the 1600s. This is housed in the Wellcome Library in London. And this is an example of a woman with presumably breast cancer. Here you see the physician in the pointy hat on the right would come over with some colleagues and along with family and friends would hold the patient down, use the equivalent of a farm tool to lop the breast off. Keep in mind, this is before the days of suture and sterile technique, so they would use on the left there the cautery irons to sear the wound shut. So as no surprise, many of these women would go on to die of things like bleeding and infection, but also they would go on to die of their cancer. But this is a fundamental important principle learned back in the 1600s, and that was the idea of local control. You needed to remove the tumor for any chance of cure. And as they would go on to learn the fundamental question that cancer is also a disease not just of the organ from which it's derived, but also a systemic disease. Many of these women would go on to die of metastatic disease. And it really brought forth the concept in question, is there a way of using a therapy that also attacks the entire body, kind of like antibiotics, if you will. And indeed, this brought forth the concept of using really non-specific cytotoxic therapies, what we call in oncology chemotherapy. And what I've done here really is given you the history of chemotherapy for breast cancer for those women who we consider to be in the curative setting. So these are patients who would have had their breast removed or the tumor removed, and then given some sort of therapy with the goal of eradicating microscopic disease and improving cure rate. And really one of the first fundamental breakthroughs was in 1975 when they tested a blend of older chemotherapy called CMF versus placebo. And this trial actually has a fascinating history as well. This trial was conceptualized and funded by the United States NCI, but because of so much controversy around the idea of using a poison in a patient who was potentially cured, they outsourced this trial to Italy, where the now famous surgeon Umberto Veronesi led what is probably the most pivotal trial in all of breast cancer, where for the first time they found by using a chemical in the body, you improve cure rates. Now, things did improve. In the early 1990s, we started having drugs that were a bit better than this old blend of CMF, including what we call AC, which is a combination of doxorubicin and cyclophosphamide. Doxorubicin is also nicknamed the Red Devil, red because it's red in color and also turns urine red, and the devil because of its side effects. These patients got extremely nauseated, they lost their hair, and there was a risk for really rare but serious toxicities like congestive heart failure and acute leukemia. In the late 1990s came the era of the taxanes, so drugs like paclitaxel and docetaxel, when added on to the backbone of AC, improved 5-year survival from about 80% to 84%. So these were, again, major breakthroughs in terms of improving curability by simply infusing a chemical. When I put this list together, though, I became very somber because It's really depressing that we have 40 years of advances in terms of chemotherapy for breast cancer, and I can fit it onto one slide in 3 bullet points. And it really brings to question why, after this beautiful advent of the concept of systemic therapies, really we've had a plateau in terms of our advances. And I think really one of the reasons for this is our one-size-fits-all approach, meaning we still take that 1600s approach where we think about all cancers based on the organ from which they came. And in reality now, with high-throughput sequencing and a better understanding of genetics, we're pulling the curtain aside to some extent and realizing that, for instance, breast cancer is not one disease, but rather multiple diseases. And if you try to approach multiple diseases in one way, it simply isn't going to work. So some real granular examples of this is from the Cancer Genome Atlas, and I'll talk a little bit about this in a moment. This is using really broad-based gene expression, looking at a variety of different tumors. And you see on top here is breast cancer. You can see breast cancer based on this gene expression is really at least 4 tumor types. And what I'll tell you is the reality is it's probably a whole lot more than 4. But what's fascinating here, if you look to the far right, you see a subtype of breast cancer, which we call basal-like breast cancer. At the genetic level, basal-like breast cancer is more similar to serous ovarian cancer than it is to other types of breast cancer. Again, reinforcing at the genetic level, one has to think about these very differently, not based on the organ from which they came. So you've seen a lot of this, but conceptually, I think this is a really important point when thinking about personalized medicine. Really, the goal and what we will always see is if you have a group of patients with a given diagnosis, if you give them a specific drug, there will always be 4 outcomes. Those red patients who get no benefit with toxicity, the yellow who get no benefit and no toxicity. These are patients who should never receive the drug. Then you have those, the blue patients, who get both benefit and side effects. This is the sort of patient you have to think very carefully about the risk-benefit ratio of your given drug. And then finally, the green people who everyone wants to be, and that is the medicine works perfectly, great effectiveness with no toxicity. So the idea really of genomics and pharmacogenomics is to use this technology to predict ahead of time who are the blue and green patients. And that's where we hope to head with this. So I make 2 major arguments as we move forward and think about application in cancer, one of which you've heard a lot about today, and that is toxicities are predictable. And we know that the SNPs and the genetic variants that Brian talked about and Dave earlier really make us each look different, make us think differently. They also impact really heavily how we metabolize and accept drugs. So the variation can affect the metabolism, the clearance, the transport, which you've heard a lot about, also can impact heavily the target tissue. And I will tell you that in the world of cancer, there are some very clear and good examples where this does impact toxicity, but it is somewhat limited. So 2 of the classic examples, one of which is UGT1A1 SNPs, which can predict both neutropenia and severe diarrhea from the drug irinotecan. There's also a classic example of DPD deficiency where these patients who get 5-fluorouracil get really bad diarrhea. The limitations is these are rare, and this is clearly not comprehensive when you think about the panoply of therapies we have and the various side effects. And finally, the clinical utility isn't clear either. So I'm going to give you some thoughts in terms of how we're going to approach this moving forward here in a bit. The second argument is that using targeted therapy is better than using non-specific therapies in almost all cases. A good example here, this was a classic example that was published in the JCO back in 2011. This is a patient on the left with metastatic melanoma. This patient has clearly a lot of skin metastases, had been treated with a variety of non-specific chemotherapeutic agents with really absolutely no benefit. By using genomic technology, was found to have a specific mutation in a gene called BRAF. And when they applied a BRAF inhibitor, you see the result on the right. And again, with targeted therapy, we see this in a variety of tumor types. In the world of breast cancer, which is what I think about most, HER2 has been that target where we have multiple drugs where we see astonishing responses, and the drugs that target this subtype of disease have literally changed the outcome for many of the women that I treat today. One of the problems, though, with this targeted approach is that it is very difficult to identify the targets. and that even after they're identified, you still have a couple decade process of designing or building a drug that gets approved for it. But I do think we are heading into an era where this is going to be much more efficient. And really this efficiency is going to be improved because of really two parallel, some way connected, some way separate processes that are happening. One is the real explosion in drug development. So we are seeing a rapid and expanding pipeline of oncogenic pathway inhibitors being developed both by industry and academia. At the same time, we've had this high throughput explosion of our understanding of genomics. So there are large consortiums, some of these international, some of these within the United States, things like the Cancer Genome Atlas, that are really cataloging 20 to 25 of our most common tumors in a very unprecedented and deep way. So in a simplistic way, one can think about this convergence as simply becoming a complex math problem, or as I like to think about it, a cancer game of go fish, where you try to identify the oncogenic lesion or the Achilles heel or the mutation that drives the cancer and simply match it with a pathway inhibitor. And one of my favorite quotes from Gladwell, I think, really summarizes this, and that is that success is not random, but rather arises out of predictable and powerful set of circumstances and opportunities. And I think we are in that era right now in the world of cancer genomics. So you've heard a little bit about next generation sequencing. So you probably all remember 2000 when Tony Blair and Bill Clinton co-announced the first draft of the Human Genome Project. As Brian mentioned, this was a decade-long project, internationally conducted, $3 billion to do. To sequence now, the sequencers are small, like you see in the upper right-hand corner, and it takes a few hours and a few $1,000s to sequence, depending on how deep you want to go with things. But the bottom line is this is now available both from a price standpoint and a time standpoint that we can use this to help at the patient level. What this has also brought forth, and this is a little more detail from the Cancer Genome Atlas, which again is a US-led consortium where they're looking at 20 to 25 of the most common tumors and have deeply sequenced hundreds of cases to really understand the genetic landscape. So here, this is one of several publications that came out last year, many of these published in very high-impact journals, really cataloging the genetic underpinnings of the various common tumors. So here you see for breast cancer, based on the sequencing using things like mutations, copy number variation, expression, the level of mutational chaos. Again, here they're able to divide breast cancer into 4 distinct subtypes. What they're also able to show are some very common and important repetitive mutations. They're able to show us which of these subtypes of breast cancers has the most mutational chaos. This is very important because that affects the ability to target therapy. But I think most importantly, this is beginning to build a real set of encyclopedias so we start to understand at a detailed level those drivers and Achilles heels for each of the various tumors, which will ultimately be beneficial as we think about our targeting of therapy. This has become a very well-recognized importance to many cancer centers. This was the lead from the New York Times back in April about cancer centers racing to map patients' genes. And what I've done here is adopted the US News and World Report honor roll. And all of those places with green arrows are major cancer centers that have committed publicly to the integration of next generation sequencing into their cancer care today. And I will tell you here at IU, I believe we are heading that way as well. So with many places thinking about this, what can separate the approach that we're going to take here at IU? And I think there are a few fundamental things that are going to be a little bit different about how we approach the integration of sequencing. One of which is many cancer centers are focusing heavily on the tumor. And what you've heard this morning is really, I think, the cutting edge in terms of understanding the importance also of the genetic variation that one inherits. So thinking about the genetic variation that the patient inherits, not just the mutations that the tumor sees. A second concept that we're going to attack a little bit differently is a concept called genomic drift. So imagine each tumor, like an animal, like this lion here, has its own life as well. And as a tumor ages and gains experience and is exposed to a variety of therapies, it becomes genomically more complicated, and it becomes a much more efficient killing machine. So pragmatically and logistically, many are starting at the most advanced line, where the patients are sickest and the tumor is most advanced. We are actually going to try to approach this at its most infantile stage, specifically in the curative setting, so that we hope to have greater success and then take these successes and learn so that we can apply them to the more advanced settings in the future. The final of which is drug selection is very complicated and I would argue not very generalizable. So for you movie buffs out there, this is Star Wars, a scene from Star Wars on the left. This is the Jedi Council. This is truly how, in my opinion, many of the centers do this today. Someone will present a genome, and a lot of smart Jedi sit around and philosophize about what they believe to be the best drug to pick. And frankly, this may be the best way to do it. And this might work really well at Houston and Rochester and maybe here in Indianapolis. This approach will never work in Huntingburg, Indiana. There simply aren't enough people and enough expertise to do this. So one thing we feel compelled to do is to try to take this very complicated system and make it more generalizable. And I'll explain in a moment what the BCS has to do with this. So this is to expand a bit on the importance of genomic drift. This was an article published in the New England Journal of Medicine in 2012. It was absolutely a beautiful article, but it was an article that made my stomach drop a bit. Here they sequenced a renal cell cancer, and what they found was genetic variation or heterogeneity within the tumor. But probably more scary was when they sequenced the metastasis from the same patient, which one would hypothesize happens sequentially in terms of time. The tumor had changed genetically. And so this, for those of us who are interested in targeted medicine, ramps up the level of sophistication when we think about hitting a specific target. So one way we hope to overcome genomic drift, at least early on, is to, in our clinical trials, strategically select tumors and settings. One of the settings that we are going to pilot, this will be our hallmark first trial, is in a type of breast cancer called triple-negative breast cancer. For these patients, what we often do, we'll give chemotherapy prior to surgery or neoadjuvant therapy. After the chemotherapy, patients will go to surgery, and interestingly, about 1 in 3 patients will have no tumor left. You cut off the breast and you see dead scar tissue. The biology here is fascinating. For these patients, nonspecific chemotherapy is the perfect targeted therapy, and their cure rate is astonishingly high. For the other 2/3, where they remove the tumor and there's nothing you can see in the rest of the body, the relapse rate is extraordinarily high, and many of these women, or the chance of death, is real. Unfortunately, the standard of care for these patients right now is observation. So what I will tell them is you had good chemotherapy, you had good surgery. Our hope is that you will be cured, but we recognize there is a real chance this is going to come back. So as you can probably imagine, this isn't an incredibly palatable situation for a patient to hear, especially since they've been through very heavy chemotherapy and surgery and so forth. So this is actually the exact population that we will first be studying. And so this is our trial design, which I've had an amazing amount of help from people, Patrick Keels here, Milan Radovich, where we're going to take patients with this sort of breast cancer who've had significant residual disease, sequence the tumor, and based on our ranking algorithm, randomize patients to a short exposure, 12 weeks of a molecularly directed therapy, or what is the standard of care, which would be for most no therapy. So really here for the first time, we're testing the process of whether genomically directed therapy can beat the standard. And the neat thing about this is very early in the tumor's life, so we feel we have here our best chance of winning. The other thing is here we're not looking for an incremental improvement in response rate, going from 20 to 25%, or a 2-month improvement in median survival, or 2-month median progression-free survival. Here we hope we ultimately improve cure rate. We also, again, getting back to the idea of generalizability, we have collaborated with a few partners, both Paradigm, Transmed, and others, who have beautiful data repositories that link a variety of these mutations or genetic differences with a handful of established targeted therapies. The problem is none of them do very well telling you which of these are the best. Within any genome, you can expect a variety of mutations or aberrations. So which of these drugs does one pick? So we have collaborated with our statistical colleagues here, Lang Li, who has really developed, I think, some neat cutting-edge statistics to help using the data that is in existence to rank which drug is your #1 drug and your #2 drug. And as he explains to me, some of our best statistical algorithms are in the world of sports. So for those of you who follow college football, the BCS is one of the most sophisticated ranking algorithms. Now, if you follow college football, you may say, no way. But the nice thing about this sort of algorithm is it does learn moving forward. So as drugs gain success, the strength of its association improves. So we'll be working very hard to pilot this sort of methodology as well to make this a more objective process. So really our vision is to systematically improve outcomes of our patients by tailoring therapy based on the uniqueness of the tumor, which I spent a little bit of time on, but also the uniqueness of the patient, which I'm going to spend a few moments on as well. So I am incredibly lucky to be here. We have cutting-edge technology in terms of germline variation. You've heard a lot today about the implementation of of SNPs that are known to be important in drug disposition in a CLIA environment. So we are certainly going to capitalize on that pipeline. That is critical. But as I mentioned earlier, really the genetic variation that may predict toxicity for cancer drug is limited. So our group is also very committed to moving forward the research program so that we can expand on the list of biomarkers for these toxicities. Really here focusing on common drugs, common toxicities, with a real focus on the clinical relevance of these findings. Some of this work has been through a very fortunate grant from Susan G. Komen for the Cure, a Promise Award. And here we have been charged with really looking for biomarkers of both efficacy and toxicity within a large clinical trial named E5103. E5103 is an adjuvant breast cancer trial. It's an international trial. It's about 5,000 patients who are randomized to that very same backbone of chemotherapy I showed you on the Veronese slide, so doxorubicin, cyclophosphamide followed by a taxane, or the same chemotherapy with bevacizumab. Here we have completed a genome-wide association study, so we have now over 1 million genetic variations in each of over 3,300 patients from this trial. So we're now able to try to map out correlations between genotype and a variety of side effects. I have by no means time to show you all the data that we've done. I just wanted to give you a flavor of how we're approaching this, one of which is a toxicity that I find really important, which is taxane-induced neuropathy. In fact, the American Society of Clinical Oncology has deemed this one of the 3 most important toxicities in all of cancer. For those who've not heard of this, it is essentially an inflammation or irritation of the peripheral nerves. It, as many of my patients tell me, feels a lot like if you're outside too long in the cold. The hands and feet begin to tingle, they become numb, they can burn. This is occasionally really bad, and it can in fact limit function, and for some of my patients is irreversible. It's also extremely heterogeneous, meaning I'll walk into one room and the young lady will tell me she is afraid to hold her baby because she can't feel her baby. She's afraid she's going to drop it, or she can't feel the stairs when she walks downstairs. And then I'll walk into the next room, same age, same drug, same dose, and she'll have none. And so we really question why there was such amazing heterogeneity, and really my strong feeling is this had to have some sort of genetic underpinning. We also showed previously that having neuropathy does not correlate with better outcome, and this is really an important thing when you're thinking about finding a biomarker that predicts for a toxicity. So in E5103, we found that those who are older and those who are obese have a substantially higher risk of neuropathy, and these had previously been seen. We actually were the first group to also show that African Americans were twofold more likely to get peripheral neuropathy, with a p-value with 14 zeros after the decimal point. So this is what we found. This is our Manhattan plot, and for those of you who have never seen a Manhattan plot, these are really cool plots that let you look at a lot of data on a single slide. So a Manhattan on the x-axis has essentially the entire genome, broken down by chromosome, so each different color is a different chromosome, and each dot represents a SNP within the chromosome. On the y-axis, you see the level of association, so the minus log 10 p-value shows that those dots higher up on the chart have a much better or much stronger p-value. So what you can immediately see, and I should point out the reason these are called Manhattan plots, it's supposed to look like the Manhattan skyline. So you're really more interested in what you see on top. Those dots high are those with better p-values. And what you can see here in looking at genetic associations for neuropathy in 5103 were several areas with interesting genetic background that seem to have nice associations. And this also tells us this is probably a pretty complicated multigenic process. But we also wanted to know whether there was a unique genetic effect for those at greatest risk. As I mentioned, African Americans are preferentially affected by this toxicity, but are unfortunately underrepresented in U.S. clinical cancer trials. And this problem is really complicated by the rich and unique genetic diversity of this population. My own belief, too, is that this is problematic to make inferences from clinical trials composed largely of Caucasians when thinking about specific markers for African Americans. So in 5103, we were very fortunate. We had about 350 African American patients who had genome-wide data. And what you can see here is that indeed the genetics look a bit different. And in fact, here we see an interesting association with a gene on chromosome 1, which is FCAM-R. FCAM-R is an interesting gene that has an important immunoregulatory effect. So the fun only begins there. These are interesting findings, but the importance of these sort of biomarkers is we are charged with also independently validating whatever we find in a GWAS in a separate trial. So we have been fortunate to gain funding and approval to validate this in a separate trial named E1199. So led by my lab manager, Dr. Shen, and with collaborations with Dr. Vance and Dr. Bai, we are now genotyping over 3,000 patients and looking at the top 200 or so SNPs within this trial. So we hope to find a marker that will validate in this trial. So this is an example. What we also will be looking at are things like markers for GI toxicity, diarrhea, nausea, vomiting, chemotherapy-induced amenorrhea or infertility, congestive heart failure. We've actually just identified a marker for bevacizumab-induced hypertension, which is the most problematic toxicity of the drug bevacizumab, and we have successfully validated this in an independent trial, and we are hopeful to have the manuscript out this weekend. Another toxicity that we think to be very important is clinically important febrile neutropenia or neutropenic infection. This is really important to the healthcare system in terms of readmissions and really important to patients in terms of inconvenience and can sometimes be life-threatening. So really what we hope to be the future of personalized therapeutics for cancer here at IU is an integration of the importance of the host as well as the tumor genomics. What we plan to do is calculate the expected benefits of the various drugs using the tumor genomics, and then calculate the expected toxicities of these same drugs using the host genomics. We would then calculate a risk to benefit ratio for each regimen, and then use educated patient focus groups to determine the optimal risk-benefit ratio for all toxicities, doing this using formal decision-making tools. And I'm glad to go into this in a little more detail if you have questions about it. It is very much in its infancy, but I think incredibly important at the clinical level. So an easier way to look at this, what we ideally hope ultimately to provide our patients with is a consumer report for their tumor. We would have a variety of regimens. We would provide them the estimated expected benefit based on the tumor genomics, and then estimated expected side effects based on the inherited genomics. And then using our formalized decision-making tools, we would pick for them what we think to be the best risk to benefit ratio. Here, we would pick regimen B. But this also empowers the patient because they may say, thank you, but I actually want every point of effectiveness I can get. I want regimen A. Or another patient may say, I'm a professional violinist. I have to feel the strings of my violin. I don't want neuropathy. I'll take regimen C. I'm okay with a slightly lower percentage of benefit. I do not want peripheral neuropathy. So we think this is really cool. For those who may be just overwhelmed with the idea of genomics, we will help them. But those who want to make a decision now have the power to do so. So today I've shown you 4,000 years of oncology. At the top you see starting from 2500 BC when the healer unfortunately had to tell his patient, I've seen this before, but I have no treatment, to the 1600s when we were lopping off organs with farm tools, to the more novel concept of using nonspecific cytotoxic therapies, to an era where I think we're beginning to be able to capitalize on the importance of the tumor genomics, hopefully now integrating with the host genomics and matching this up with the appropriate targeted therapy so we can really puzzle together for each of our patients that best therapy. So I'll conclude by saying that hopefully I've shown you tumors are different at the genetic level. You've seen a lot today about the fact that we as people are different, and by using a personalized approach, I strongly believe we can optimize the effectiveness of the drugs, minimize the toxicity, in doing this actually save healthcare dollars, but at the end of the day do the most important thing, and that's take good care of our patients. So I will stop there and glad to answer any questions.
Hi, thank you for your talk. I am as far away from oncology as I could ever be, and it's still very applicable to lots of things. When you were talking about calculating the risk-benefit ratio, did you have in mind developing something on your own or something more like an NT and NH or a clinical application?
Yeah, as I mentioned, this is very much in its infancy. So by the way, if this is an area of interest for you, I am here to listen. I want to make this better. The first iteration of this was very simple at the onset. This was led by a group I collaborate heavily with called the Research Advocacy Network. And they accumulated over 400 patients who had had breast cancer and been exposed to therapies. And what we first realized is that not every patient's had every side effect. So we spent 2 to 3 full days explaining what neuropathy means. Very detailed level. What is serious neuropathy? What is mild neuropathy? What is moderate neuropathy? And then we do the same thing for the next side effect, heart failure, to really give them a flavor of what it was like for those that had it. And then what we did is said, okay, we'll assume given a given benefit to the drug, here's the risk of neuropathy. Are you okay with it? And then we just started using the Coke versus Pepsi decision-making tools, figured out a threshold at which patients started saying, whoa, this is too high. Then we would do the same for another drug and another side effect so that we could start seeing on the curve at the point which patients began to think this toxicity is now starting to outweigh the benefit. And then we would shift the benefit portion as well. So it's a start in looking at a couple of our major toxicities, but at the end of the day, our vision is to do this for every side effect.
So is it like you're taking more of a qualitative approach?
Correct. The way we currently do this is actually horrible. So we use a CTC criteria, the common toxicity criteria for cancer. And so the definitions for each of the toxicities is frankly quite poor. So if you ask a neuropathy expert to look at the neuropathy grading, they will tell you, oh my gosh, this is horrible. If you ask a cardiologist to look at our definitions for heart failure, they want to pull their hair out. So it can be a lot better. Yeah. All right, thank you.